Let's spend just a few minutes talking about our approach to treating osteoarthritis. Now, we're going to spend most of our time talking about osteoarthritis of the knee, but really a lot of these things are applicable to osteoarthritis of the shoulder, elbow, hip, even ankle. You know, there are a lot of different things on the market being advertised, etc., about things that would help you with your osteoarthritis pain. Things that are very traditional and minimally invasive or intrusive in any way. Physical therapy, use of a knee sleeve if it's a knee, use of certain other over-the-counter anti-inflammatories, Tylenol, stretching exercises, yoga, Tai Chi, lots of things have made the common marketplace, and by the way, they all have a place and they just about all work. Chiropractic care is frequently advantageous for people to use. And then there are things that are a little more invasive but not surgical. Starting with the least of these would be prescription strength anti-inflammatories. Some people swear by glucosamine and chondroitin. Some people really don't think it works very much, but it has been experimentally shown to slow down arthritic deterioration or progression. I'm kind of a believer, but some people can't take it due to gastrointestinal issues. And then there are things that are a little more invasive but still not surgical. Things like steroid injections or viscose supplementation, which you may have never heard of, and we have another video that goes into greater detail explaining viscose supplementation. Simply stated, it's hyaluronic acid, injections or derivatives of hyaluronic acid, which stimulate your joint to make better joint fluid. Sometimes that's all people need to get excellent pain relief because it lubricates the joint and gives them a better shock absorber. Beyond that, there's Prolotherapy. Prolotherapy has been in existence since the 1940s or 50s, depending upon how you view it, and it involves injecting substances which cause a proliferative, or think healing, action in the joint or the tendon in which they're introduced. Some people are believers in this, and some people aren't, but the far-reaching evidence is that this also has a place in our armamentarium. The next injectable therapies would be cellular therapies. I'm only going to deal with the autologous cellular therapies, which means the things that you donate the tissue and we put back into you. But there are non-autologous, which means allograft tissues, such as growth factor therapies from placentas. We have used those, and amniotic fluid-derived stem cell therapies, which are very new on the field. And we don't have a lot of experience with those, but you'll read about them in the literature if you look. The cellular therapies that we offer are platelet-rich plasma, where we take your blood, centrifuge it, take the platelets out of your blood, and re-inject it into the site that we're treating. Beyond that, though, there's also what we call mesenchymal cell therapy, which isn't really a stem cell therapy in the way you think about it, because it doesn't come from embryos, it comes from you, but is a progenitor cell therapy. Now, this will very commonly be called stem cell therapy, but I don't want you to be confused and think it's a stem cell therapy like from embryos or from babies or from laboratories. Those are cells that we can procure from you and put back in you that then become local tissues and heal those local tissues. Two primary sources of your stem cells that we use are those that come from bone marrow, which are better stem cells. They can become more tissues and they get more divisions in them, but you have fewer of them, and particularly over time, those numbers decline. Or, believe it or not, the second best source of your stem cells is from your fat. That's right, your fat. So I don't think of myself as being overweight. I think of myself as being a stem cell reservoir. But from the fat, which we actually get out of you from liposuction, no kidding, a mini liposuction done in our office under local anesthesia, we can then take that out, emulsify it, centrifuge it, and take the stem cells out of that, just like we get the stem cells out of your bone marrow extract. If we re-inject those stem cells, which still have to be stimulated from the platelets from platelet-rich plasma, we can actually heal some local tissues the best that they can biologically. Typically, that works about 80% of the time at helping people regrow enough joint surface or repair joint surface to the point that they would not need surgical intervention. That also has to be boosted one more time because the platelets die in about a month, but the stem cells are still working. So we would typically do a second platelet-rich plasma procedure to the area. And then there are those people who, for whatever reason, don't have the other procedures, Some of those reasons are cost, because the cellular procedures, particularly the platelet-rich plasma and the mesenchymal cell, which you would think of as a stem cell procedure, are not covered by insurance and they can be costly. So in those cases, for people with knee arthritis, hip arthritis, those people need joint replacement. Now, I've been in practice for 25 years as the date of the opening of this practice, since the middle of 1990. So I've got plenty of experience at doing hip and knee replacement, because you can't be an active orthopedic surgeon in Southwest Florida who treats hip and knees and not do a lot of joint replacement. So we are prepared to do that if you need it, but if you really don't want to have surgery, you just heard from the prior portions of this talk, we have lots of options for you to get you playing tennis and golf and traveling with the grandkids or whatever you choose to do and not have pain and not have your function limited. I hope this was educational for you. I appreciate your time with us today. I am Dr. Ron Gardner with Gardner Orthopedics.